to ask you all about scientific evidence in this area, in this disease. And there's sort of the pre-approval science. There's what we learn in the post-approval and sort of real-world implementation phase. I think we've identified some risks over the years that maybe the studies didn't completely, sort of elaborate on. And we have some producers of research here, certainly consumers, and Zach, you're an editor of a journal. So maybe I'll start with you and just ask your thoughts on the science and sort of the process of developing science. Any thoughts you have in terms of how we might need to do that better, where we might need some changes?
Okay, so one very important thing is to look at the inclusion and exclusion criteria of every trial.
Yes.
And make sure that the trial participants really resemble the person that you're sitting in front of who you want to choose a medicine for. And so there was a lovely analysis of the Scottish Diabetes Database, which then looked at all these large cardiovascular trials going from PROACTIVE to ACCORD, VADT, and so on. And they found that if you look at how representative the trials are, they go from about 3% to at most 30% of people with diabetes in that community. Well, that's a big dilemma. So either 2/3 or 95+% aren't going to fit the characteristics of the people studied. And that absolutely is going to apply to these cardiovascular safety trials. So before we say everybody should take empagliflozin, we might want to say, well, everybody who resembles those 6,000 people who were carefully selected to have a certain level of risk factors. On the other hand, if we look at the larger epidemiologic databases and say, well, those individuals who took DPP-4s have better cardiovascular outcome in the community than those who take sulfonylureas. Well, do we really know that there's not some bias that led physicians to prescribe DPP-4s to individuals with different socioeconomic or educational or other characteristics from those who got a sulfonylurea? If so, those may be the real causes of the apparently better outcome with the DPP-4. So a lot of questions, and I don't know that we'll ever get the answer.
I mean, there's a limit to, I think, how much we can data mine from, retrospective data to say that something is safe, more effective. I think it's hypothesis generating and helpful, and certainly there have been numerous examples where signals of problems were identified through large data sets, but it can't quite be definitive.
Right.
And for better or worse, these large trials, which fortunately, I mean, as we're talking in just the last few months, there have been seismic changes in the way we're thinking about managing our patients because of these trials.
But it's important still to do some post-monitoring.
Absolutely, for safety especially.
Absolutely.
Right, for safety
But we
especially.
also have to be careful not to overreact to small signals. So recently, there have been a few reports that the DPP-4 inhibitors might be associated with a kind of arthralgia syndrome. So millions of people have taken these drugs. 33 cases were reported to FDA. And it sounds like those people did have a reaction. But, I have 33 people in my office every week who have terrible arthritic symptoms. And how did those few cases lead to a warning label on every product information for a DPP-4 inhibitor? So we have to do it the right way.
Well, I mean, the same could be said for the DKA with the SGLT2s. When you really start to parse down the data, is it really all that unexpected? Is it any different than the comparators? And it's really beginning to look like it may not be.
Although actually we had an ACE conference on that whole phenomenon, and there's some fascinating science behind it.
Interesting science.
And it turns out that, for utterly unexpected reasons of SGLT2's role in the alpha cell and effects on on tubular reabsorption of ketone bodies, it may be that this really is sometimes an issue.
Why don't we move to our last segment here, talk a little bit about quality measurement, quality metrics, and so forth. You know, anytime, and Bob, maybe I'll start with you, anytime we think about quality metrics, HEDIS type measures and such, you know, people often point out patient compliance and variation across patients in terms of their behaviors. And, you know, diabetes is an area where willingness to adopt a healthier lifestyle, to exercise, to diet can really significantly make a difference. So, you know, I guess from your perspective, maybe not only in choosing a therapy and a treatment for a patient, but also thinking about from a population perspective, the impact as that might show up on a quality measure. You know, wondering thoughts that you might have about the
Yeah, you know, I mean, number one, I think we need more nuanced quality measures that take other things into account. But in the absence of that, I think, you know, all of the quality measures and, you know, things that we see from managed care and elsewhere, the goal is not that 100% of patients should meet any goal, but there's an exception for a percentage of patients that, based on individualized needs and cases and comorbidities, are not ideally suited for that therapy. The other thing I'm always a little nervous about is as a healthcare community, us saying, well, it's all about patient adherence, and so that's not my problem. And well, no, we have an important role in that, and there's certainly interventions that we know that can improve adherence and engagement of patients, and I think it's part of our duty as providers to be able to guide people to do the things that will be better for their health.
You know, I so agree with what you're saying, Bob, and one of my arguments with the American Diabetes Association's latest guidelines is that they show many dimensions of decision making as to how low or high an individual's A1C goal should be. And one of them is the person's willingness to treat their diabetes, as it were, their adherence level. But we could use that and we could say that anyone who's perhaps not sufficiently motivated because of all sorts of extrinsic factors, we would say, well, that's not someone we're going to try to treat so well. And yet, that's not fair to that individual. You know, if a person has to commute an hour and 15 minutes each way on the New York City subways to get to work and doesn't have time to bring healthy food with them, but instead has to get something at the local deli and then has no time to exercise, should we say, well, this is someone who we're just not going to try to work on lifestyle? Or should we say, well, how can we re-engineer his life environment to help him or her to be able to do this?
I think the important thing with the quality measures, though, is that they're a proxy for helping us manage the outcomes.
Sure. And the overall population.
Exactly. So if we have a better look into, from a population health perspective, those patients that have a diabetic retinal exam or have a hemoglobin A1C and they're controlled, from all the studies that we've referenced, we know that we can use that data to predict or at least manage better the downstream effects from poor quality. So that's really where the managed care population steps in and likes to partner with the provider and specialist to say, how can we improve the quality such that we can control some of the downstream costs?
So your Medicare Advantage plans obviously have a market basket of quality indicators that aggregate up into star ratings that have a fairly significant financial impact depending on how you do. Diabetes, of course, is just one of many conditions reflected in those. Any thoughts, John, on sort of the relative weight that the diabetes gets in general in the determination of those plan ratings, or the specific quality measures around?
Yeah, so if you look at a STARS rating, again, the biggest components of STARS would be HEDIS and CAPS. And CAPS is the consumer survey that the general public, if they're included in the sample, they fill out and give an assessment of the care they receive from their health plan, whether they have diabetes, the care they receive from their provider. The HEDIS gives us more quality data on how the provider and the patient, the member, is performing. And diabetes is high because some of the measures are triple weighted. And so controlling of blood pressure, controlling of HbA1c, medication adherence, not just that the doctor did a great job of prescribing it, but is the person actually taking it and getting it filled. So all of that weighs heavily into the assignment of quality performance and in STARS rating.
Although I assume the medication adherence is subject to the discussion we just had, which is within a sort of endogenous choice situation around
Right.
with the best. Yeah.
And controlling for the severity of illness is so important. So, you know, endocrinologists tend to see those individuals who have the higher level of illness, who have the higher A1C, and there have been some, maybe the earlier analyses, which said, oh, endocrinologists have worse outcome than primary care. Well, sure, if they start with much more ill patients.